Welcome everyone to Chicago Autism Network's virtual parent workshops. Tonight we are really excited to have Dr. Laura Bliss come present to us. Dr. Bliss is originally from Riverside, California. She did her undergraduate work at University of California, San Diego, and received her MD from Washington University School of Medicine in St. Louis. She completed her pediatrics residency through Northwestern at the Lurie Children's Hospital in Chicago. She is currently a senior child neurology fellow at Lurie. And her interests include genetic factors in epilepsy, autism, and cerebral palsy. So we'll turn the time over to Dr. Bliss.
Thank you so much, Kimmy. I wanted to start, and I'll get to sharing my screen soon, but I kind of wanted to get a sense of how many people have a child with epilepsy or know someone with epilepsy. My talk is a little bit on kind of the more like 101, seizures 101, and I don't want to go too basic if a lot of people kind of already know a couple things. So if you want to write in the chat or like do the hand raise, if anyone is familiar with epilepsy or seizures. And seeing 2 so far, 3. Okay. I see. Bex, gotcha. Okay. All right, so it sounds like a smattering of people. So I just let me know if it's a little bit too basic for you. If you have questions, I'm happy to answer them at the end. All right, let me go ahead and share my screen. All right, can everyone see my screen? Great. All right. Well, like Kimmy mentioned, I'm Laura Bliss. I am one of the senior neurology fellows over at Lurie Children's. And I'm excited to talk to you guys today about epilepsy and autism spectrum disorder. Excuse me. I have no financial disclosures. And I'll just kind of set the stage. Why am I talking about epilepsy and autism? Why is this an important thing for me? And to start, I wanted to include some of the primary and secondary data that we have on this topic to share with you. This is a recent review article that describes the relationship between epilepsy and autism spectrum disorder. And the relationship is that there is both an increased incidence of epilepsy in patients with autism spectrum disorder, and then vice versa, there is an increased incidence of autism spectrum disorder in patients with epilepsy. And we know that patients with autism spectrum disorder are at a higher risk for seizures. And then it kind of follows a bimodal tract. So toddlerhood is a time that they're at higher risk. There's a drop kind of during school age years, though they certainly can still develop epilepsy. And then adolescence is also kind of a peak. And it's estimated that about 1/3 of patients or people with autism spectrum disorder will have seizures in their life. And then one thing we do know is that comorbid intellectual disability is further a risk factor for epilepsy in patients with autism spectrum disorder. Kind of backing up and looking at the worldwide epidemiology, the worldwide prevalence of epilepsy in the general population estimated by the WHO is between 0.4% and 1% worldwide. And there's kind of mixed data on this, but the prevalence of epilepsy in people with autism spectrum disorder is thought to be somewhere between 11% and 39%. There's a lot of varied data out there, but all of them kind of center on the fact that the incidence is much, much higher. And then I'm so sorry, I don't think I can see the chat, but if there are any questions, feel free to just, raise your hand or maybe interrupt me. I'm happy to kind of stop and discuss a slide a little bit more. So I mentioned a little bit earlier that intellectual disability is a known risk factor for epilepsy in patients with autism. This particular article was a meta-analysis from 2008 that compared the prevalence of seizures in patients who had autism, both who had intellectual disability and those who did not have intellectual disability. And in the study, they defined intellectual disability as an IQ of less than 70. And the three things that kind of jumped out from this article were that in patients who had autism and comorbid intellectual disability, their prevalence of epilepsy in that group was about 21%. In patients who had epilepsy but did not have intellectual disability, that number dropped to about 8%, though they were at a higher risk than the general population. And then interestingly, they found a female predominance in this large group compared to males. So females who had autism spectrum disorder, regardless of intellectual disability or not, were more likely to have epilepsy than their age-matched males. And the kind of ratio that they came up with was about 2-to-1 in this study. Okay, really basic, but I just want to stop for a minute and discuss what a seizure is. And we basically define it as a burst of uncontrolled electrical activity between brain cells. I included a couple EEGs or electroencephalograms that I like to look at all the time. The one on the left is a normal EEG, kind of with these wave-like patterns. The one on the right is a person who begins to have a seizure right here and then continues on, and they have a much more rhythmic or choppy activity. So not all seizures look the same. In fact, seizures will affect a person differently depending on what part of the brain is affected, because different parts of your brain control different parts of you. So for this slide right here, I wanted to introduce our current classification system for different types of seizures. This is from the International League Against Epilepsy, and they came up with this pretty recently, about in 2017. So a lot of people may have older terms that they kind of grew up with or understand. These are the current terms that we're using. So for focal onset seizures, I'll start with this one. This term refers to where the seizure will start in the brain. So seizures can start on one side of the brain or with a particular group of cells in the brain. We call that a seizure focus. And focal seizures are very varied. They can have motor or non-motor components. Motor components will be things like stiffening of one side of the body, shaking of an arm or a leg or both. You can have eye deviation or head deviation to one side. Sometimes you'll get face, mouth, or cheek twitching with it as well. And then when it comes to non-motor components, that can be anything from a feeling or a sensation that a person feels. A pretty common one that we'll see is what we call a behavior arrest. So you'll see it also in absence seizures that I'll talk about. And that's when a person is just kind of going about their life and doing things, and then all of a sudden they just kind of stop and stare and are gone for a couple seconds and then kind of come back as if nothing happened. We also differentiate between whether a person is aware during their seizure or if they have impaired awareness. So when there's preserved awareness in a focal seizure, this is when a person is having a seizure and is aware of what's going on. And for focal seizures with impaired awareness, the person will actually lose awareness, sometimes lose consciousness, and won't remember the event.
I'm sorry.
Yeah, go ahead.
Someone in the chat just typed nystagmus ? In focal ? Does that?
Yes. Good pickup. Nystagmus can be seen in focal seizures. I don't necessarily see see nystagmus in generalized seizures. Nystagmus kind of relates to eye deviation that we'll see sometimes. And it typically, when I see it, I think focal seizure. Interestingly, maybe only to me, but the direction that the nystagmus is beating, and I'll quickly describe nystagmus. It's kind of a jumpy, jerky eye movement in the direction of vision, or sorry, of gaze, that we can sometimes see in seizures and without seizures. But yes, we can certainly see nystagmus with focal onset seizures. That was a good pickup. I'll move on real quick and talk about generalized onset seizures. These, unlike the focal onset seizures that start in one part of the brain and can spread, these seizures start on both sides of the brain, where all of the brain starts seizing at once. And when both sides of the brain are involved, awareness is always impaired. And I always think of it as you need at least one side of your brain to be working properly to be able to be conscious and know what's going on. So awareness always impaired. These can include tonic-clonic seizures. These are the ones that I call Hollywood seizures, because they can be kind of dramatic. There's stiffening and shaking of the whole body. The person will fall to the ground because they're not able to control their movements, and they can actually be pretty terrifying to see. Absence seizures are seizures kind of like I described before, but it's a generalized seizure where a person will stare. They might have kind of an automatism where they might chew or kind of play with their shirt a little bit absentmindedly. And then atonic, we'll often call these drop attacks. This is when someone will just lose tone in their body and often fall to the floor. They're very brief, but obviously can result in some injuries if the person's in a dangerous situation. And then sometimes a focal seizure will progress really quickly to be a generalized seizure. So it's hard to tell exactly where the seizure is starting. And we'll just call it like it is, a seizure with unknown onset, and keep trying to find out if we can. So I kind of described seizures. I'll talk a little bit about epilepsy, which is essentially I think of it as an increased risk for having seizure. So someone who's more likely to have a seizure than someone else. It is typically marked by recurrent unprovoked seizures. And unprovoked means that the seizure happened without it being a symptom or another process or disease. So examples of a provoked seizure can include seizures due to infections like meningitis, severe head trauma where there is severe contusion or bleeding in the head, or toxin exposure or drug ingestion that can cause seizures. So a person can be diagnosed with epilepsy if they have 2 unprovoked seizures. So none of the above that caused it, they just had a seizure, or 1 unprovoked seizure with the likelihood of more. And I'll kind of explain what that means in a little bit. So seizures are actually pretty common. We see them a lot, especially in child neurology. It's estimated that about 1 in 10 people worldwide will have at least 1 seizure in their lifetime, whereas 1 in 26 people worldwide will develop epilepsy during their lifetime. So typically it's not necessary after the first seizure for neurologists to start an anti-seizure medication for people in the general population who've had a one-time seizure, because many people will go on to never have another seizure in their life. However, there are some risk factors that increase a person's risk for developing epilepsy. For example, we know that people with autism spectrum disorder have a higher rate of epilepsy than the general population, and we qualify that as a risk factor. An abnormal EEG or electroencephalogram after a first seizure could also indicate a higher risk for further seizures. So I'll talk a little bit about the EEG. often after a first-time seizure, families will bring their loved ones to the emergency department where they will be assessed by a healthcare professional. Um, in the acute setting, the person will be evaluated for any of those provoking factors that I mentioned. So they will screen for trauma, infection, or drug ingestion. And if the seizure is determined to be unprovoked, at least in the pediatric neurology world and at Lurie where I work, we are very likely to order a screening EEG to look for abnormalities that would indicate a risk for recurrence for that person. So I'll give you a few examples of the EEGs. They are, I imagine some of you have seen these. You put little stickers on the head and they measure the brain waves, essentially the electricity between different parts of the brain. This is actually the EEG of one of my patients, just with all his information taken out. And this is what his background kind of waves look like. These are eye blinks, actually, so nothing is really jumping out to me as abnormal here. However, this is an EEG where we did catch him having a seizure. And if you notice, compared to the other one, there's this rhythmic, high amplitude, kind of angry looking activity that is coming actually from the right side of the brain and continues until the end of the seizure. Oops, excuse me. We aren't always able to capture a seizure on EEG because that would require you to be having seizures a lot so that we would catch one just on a screening EEG. But we can still use it to look for risk of seizure. This is the same patient that I mentioned before, and he at rest when he's just, eating food, watching TV, we're monitoring him, and he has, if you'll kind of pay attention to this kind of extra electrical activity over on the right side, this patient is having, every once in a while, having what we call interictal discharges or abnormal electrical activity coming from that same area where we know his seizures are coming from. So this EEG I would classify as abnormal, and after knowing that he had a seizure, I would be comfortable diagnosing him with epilepsy. And kind of like I mentioned before, epilepsy can be diagnosed if you have 2 unprovoked seizures, regardless of your EEG, results, or 1 unprovoked seizure and an abnormal EEG. I do want to make a quick aside about EEGs. It turns out they're kind of complicated, a little more than that. The EEG will give us a really good indication of who is at risk for continued seizures in people who have already had seizures. The problem is that some people have abnormal EEGs, even though they've never had a seizure in their life. So if I picked 100 people off the street who've never had a seizure in their life, some of them will have abnormalities on their EEG, and we would have never known unless we connected them. The other problem, and I'm just including another review article, is that people who have autism spectrum disorder who also have never had seizures in their life are more likely to have abnormalities on their EEGs than age-matched controls. So in addition to being more at risk for epilepsy, they also are known to have more abnormalities on their EEG, even if they never have a seizure in their life. So essentially, an EEG alone is not enough to diagnose epilepsy or even comment on the risk of further seizures, unless it is in combination with an unprovoked seizure. So an EEG alone is not enough to kind of make a diagnosis or counsel a patient. However, if it is in combination with an unprovoked seizure, we do have some data to back up how likely it is that another seizure might occur. And I can talk a little bit about that in a bit. I also wanted to share some of the more up-to-date data that we have. I talked a little bit about, what happens after the first unprovoked seizure in children, just in the general population. But this recent study actually came out earlier this year and it looked at the recurrence rate of the first non-febrile seizure in children who have autism spectrum disorder. And in children, we often describe fever as a provoking factor because in very young children, we can see patients have febrile seizures that don't necessarily predict a risk of epilepsy in the future. So it was a pretty interesting study. It was done at Vanderbilt, and they looked at medical records of pediatric patients who were seen at their institution between 2006 and 2016. All of them had autism, and they were seen in the emergency department or in the neurology clinic for a first-time non-febrile seizure. And then they calculated the risk of recurrence of non-provoked seizure over the next 2 years. And there were about 141 patients in this cohort. And they had a lot of things that they kind of went through in their article, but I wanted to pull out some of the more salient points. There is a high recurrence rate after a single non-febrile seizure in pediatric patients who have autism spectrum disorder. So about 70% of them in the 2 years following that first one did have a recurrent seizure. Additionally, an abnormal EEG had a very strong predictive value of seizure recurrence. So patients with autism who had a single non-febrile seizure, 90% of them had another seizure in the next 2 years during this study. So I'll kind of pivot. I talked a lot about why I think talking about this is important, especially for autism spectrum disorder. But I'll kind of flip it and tell you a little bit about what I do in my clinic with the neurology. I think most pediatric neurology departments do. And if your child is diagnosed with epilepsy, they will need to follow with a neurologist or an epileptologist. And on that first visit, there are 3 things that the medical team are going to want to discuss with you. Why does this person have epilepsy? I always think of epilepsy as a symptom and not a disease. A lot of people have seizures for a lot of different reasons, sometimes genetic, sometimes due to trauma. So there's often a deep dive into why this is happening. How do we prevent more seizures? Importantly, I'll talk a little bit about that. And then what do we do in the moment when a seizure happens? Especially if there's a high risk for another seizure, we want to be prepared and we want our families to feel safe and empowered that they can handle a seizure if it happens. So depending on the type of seizure and the patient's history and their exam, the doctor may recommend brain imaging. And this would be to look for signs of a structural difference in the brain that could lead to seizures or signs of a remote injury to the brain that could also provoke seizures in the future. And just to bring it back to that patient whose EEG I showed you before, this was his MRI, and I'll tell you it was normal. We were not able to find anything abnormal in his brain that would be a reason for his seizures. Genetic testing, we're doing it more and more these days. It may be recommended by the team or the medical team because many types of epilepsies are associated with a genetic mutation. How do we prevent more seizures? So usually the first line seizure prevention in a person with known epilepsy is an anti-seizure medication. There are a ton out there. We will often work with the families to try to find a medication that fits the epilepsy, the type of seizures that the patient has, their lifestyle, how many times a day they'll have to take it, what the side effects are, and then trying to limit unavoidable side effects. Unfortunately, most medications will have some unwanted side effects. And unfortunately, sometimes it can take some trial and error to find the best medication regimen to prevent seizures. A statistic I hear a lot is 2/3 of patients who have epilepsy were able to gain control on that first med and do very well on that. There's about 1/3 of patients who need a little bit more trial and error to find the right medication for them. If medical intervention is not successful, there are dietary modifications. We have a lot of patients at Lurie who are on the ketogenic diet, or the modified Atkins diet. There are implantable devices like vagal nerve stimulator, VNS or RNS. And then we do a lot of epilepsy surgery for certain types of epilepsy at Lurie as well. And that it's actually becoming a very popular way and a very successful way in certain epilepsies to stop seizures. Avoiding or identifying and avoiding seizure triggers can also be very important. This is from the Epilepsy Foundation, and it is kind of a seizure app or a seizure tracking app. I think it's pretty helpful, and parents or patients with seizures can kind of track how long the seizure was, when it started, anything that happened during that day that might have been like a triggering factor for bringing out a seizure. And then over time, they can identify patterns and try to avoid any possible triggers that they find. Some of the common seizure triggers that we notice are mismedication. Sleep deprivation is huge. Stress, alcohol, and drug abuse can also bring out seizures. I think of stress more in kind of physiologic stress. So having a fever, being sick, similar to sleep deprivation, being up all night, putting stress on the body. A lot of people ask about kind of emotional stress or a mental stress. And I don't know that much research has been done on that. I know anecdotally, some of my patients feel that when they are under a lot of stress at school or home, then they have more seizures, but I don't have any data to back that up. I will also sleep deprivation and alcohol. I tell all my teenagers to watch out for that and not pull any all-nighters in high school or in college, because it's a big risk for bringing out more seizures. Menstrual cycle and nutritional factors can sometimes bring out seizures. And then certain over-the-counter medications. There are some cough medications that I'll ask my patients to avoid, just because some of the active ingredients can lower the seizure threshold, so to speak, and make a person more likely to have seizures if they have epilepsy. What if a seizure happens and you witness it? And I realize this is kind of a long talk, but if there's anything that I would want people to take away from this discussion is Seizure First Aid. I think it can save lives and makes a huge difference. This is a little infographic that I got from the Epilepsy Foundation. And it kind of goes through everything that I will discuss with families in that first visit and all the visits, to make sure that they feel comfortable and are able to kind of act on this. So they're basically, stay with the person. If they're awake and alert after the seizure, that's great. Kind of talk to them and see if they're returning to their baseline. If the seizure looks like it's going to last a while, more than a couple seconds, remain calm, and try to time the seizure if you can. It's often not the first thought that someone gets is to look at the clock when someone has a seizure, but it is important to kind of keep track of how long the seizure goes, for management in the future, and also for current management, because we don't want seizures to go on too long. Importantly, we need to be able to keep the person safe if they're having a seizure. So I always say, in kids or in adults, even if you can, to try to get them to the ground as safely as you possibly can, and then always turn the person on their side. The reason for that is when you're kind of stiff and shaking and kind of out of control, it can make you vomit or throw up. And if you're on your back, we don't want the person to accidentally, choke on the vomit. So always on the side, so that if there is vomiting, the vomit will go out of their mouth and not back in. If you can, loosen tight clothes around the neck so that they can breathe. And then it says put something small and soft under the head. If you're at home, you can grab a pillow. I always say just kind of keep them away from, sharp corners or, anything that they could fall off of. Something important, or two important things I want to note, is don't try to stop the seizures from happening by restraining the person, especially in real little kids. They can't control the movements, and trying to stop the movements by holding on to them will not make them stop. And in fact, if you restrain them too hard, you could cause, some bruising or, even a fracture or something, that they're moving so aggressively or so strongly that you could actually cause some injury by trying to restrain them. And then never ever put anything in a seizing person's mouth. I remember even in med school, I heard some people saying, oh, like a spoon or a wallet or, something to keep them from swallowing their tongue. You can't swallow your tongue. That's an old wives' tale. In fact, having something in your mouth is actually more of a choking hazard. So nothing in the mouth, head to the side, time the seizure, and kind of go from there. And the reason I want people to time the seizure is that around the 5-minute mark, we start getting worried that a seizure will not stop without medical intervention. I will mention that most seizures will stop on their own before 2 to 3 minutes. And I want to be reassuring that seizures that short don't do any damage to the brain. As scary as it is, it's not enough. It's not enough time in that seizing state to actually cause any brain damage. So as uncomfortable as it is to watch someone having a seizure, and as scary as it is, reassurance that short seizures do not cause brain damage. Long seizures, on the other hand, and by long, I mean lasting 30 minutes, an hour, hours, we do start worrying that there's enough metabolic stress on the brain and the body that there could be some injury done to the brain. So that's why at that 5-minute mark, we really want medical intervention if possible. If it is someone with known epilepsy who has a rescue medication that their doctor has prescribed, that would be around the time that they would give it, unless you've discussed a different plan. And anyone who does not have a diagnosis or a known rescue medication, that would be the time to call 911 and get some help. All right. Some other considerations that I wanted to just bring up are seizure safety, school precautions, suit up. You can also bring up driving in older kids. Seizure safety, or seizure precautions, we like to call them. I always say anything that could cause harm if someone were to be suddenly unconscious or unable to control their body is something that they would need to be supervised for. I always say, like, sky's the limit. You can do whatever you want if you have epilepsy and you can live your life. There's a couple things where I want someone to be watching you and making sure that you're safe, but I don't want to restrict people from activities that they like. So one-to-one supervision for baths and for swimming. Helmet when riding the bike. I hope everyone's kids are wearing a helmet when they ride a bike. And then avoiding climbing to heights. We always say above shoulder height, unless you're in a harness. I used to love rock climbing, so I wouldn't want to preclude anyone from rock climbing if they liked it, but I would prefer if they are strapped into something where they would be safe if they suddenly lost consciousness. These are actually some artworks by one of my colleagues, Dr. Akbari, over at Lurie. She made a mnemonic, water, wheels, and heights. A little bit of alliteration there, but not quite. And she did this artwork. So I just thought I would share it. School precautions for the people on the Zoom who have family members or children who have seizures, you probably know a little bit about this. Most schools will require that you have what we call a seizure action plan. And we strongly recommend that we give your school a seizure action plan for kids who have epilepsy, because it, I think, is really helpful in an emergency situation. I'm including my seizure action plan for one of my patients. This is just kind of our Lurie template that we use. We can also fill out a school's form if they send us one. So just kind of the stuff we go through, the type of epilepsy the patient has. You can't see it up here, but a way to contact our office if needed. What their daily seizure medication is. This person has an emergency medication. And then just some basic seizure first aid just to kind of remind people, and then their emergency protocol. So some patients, we will prescribe them a rescue medication, and in their plan will say, at this time, give the rescue medication, wait, give it again, or call 911 or call the office. Everyone has kind of a tailored plan for them. And then hopefully the thought is that that kind of gives the school a tool to best help the student who is having a seizure at school. This is always a really difficult topic, because it's very scary, but I think it is very important for neurologists and for any advocates for people with epilepsy bring up. It's SUDEP, or sudden unexpected death in epilepsy. This is a infographic from the Danny Did Foundation that I like. And I'll give you guys some resources and references that I use, but I do like this infographic. SUDEP is kind of a mystery. It's essentially where someone passes away, they have a diagnosis of epilepsy, and no cause of death is found, and it is attributed to their epilepsy. And it's more common than I would like. Obviously, about 1 in 1,000 people with epilepsy will die each year from SUDEP, give or take. The incidence in pediatric patients and children is actually much lower. It's about 2 to 3 per 10,000 patients. So thankfully, it's a lot lower in children, but still something to keep in mind. And then, kind of like I said, the cause is unknown, which makes it a really, really uncomfortable thing to talk about, because if we knew the cause, ostensibly we could come up with a way to prevent it. So it's, it feels awful to talk about when I can't offer something, to stop it. However, there are some risk factors and risk factor modifications that we can take into account. And at visits with my patients, I like to, go through and make sure, that we are managing risks as best as we can. So taking meds as prescribed is very important. Missing medications can increase your risk for SUDEP. Getting enough sleep, kind of as before, if your sleep schedule is all over the place, or you're staying up all night and not really on a good sleep schedule, that can very much increase your risk for seizure. This is a particularly, I think, difficult at times a risk factor to modify in our patients who do have autism, because sometimes sleep can be a little bit more of a challenge for those families. So definitely something to work with the physician and and try as best as we can to try to modify that risk factor. Train family and friends in seizure first aid. It can save lives. Knowing your seizure triggers and trying to avoid them if possible. And then it's not entirely known why, but people who have seizures at night are actually thought to be more at risk for SUDEP. So talking with your doctor, considering a seizure monitor or an alert device that the patient can wear to try to alert the family if a big seizure were to happen. I don't think it's on this infographic. Oh, yes, it is. Some risk factors to point out would be badly uncontrolled seizures. So either not taking the medications as prescribed or the medicines aren't working and we need to try a different one. Those big Hollywood seizures I talked about, patients who have those are at a little bit more risk. And then, like I said, nighttime seizures. I wanted to talk about most of the information I was alluding to came from the Epilepsy Foundation. They are a great resource for physicians and families. I highly encourage everyone to take a look if they're so inclined. The International League Against Epilepsy is kind of a resource for doctors, but I'm putting it up here in case anyone is interested. It has a lot of diagnostic criteria, resources for families that physicians can give out, and just a bunch of good information about treatment, adjunctive treatments, diagnosis, and support. And then I wanted to mention the Danny Did Foundation. I had an infographic from them. They are a great nonprofit here in Chicago, run by a family who their son, Danny, unfortunately, he had epilepsy and passed away, I believe, at the age of 6 due to SUDEP. And they have, in his honor, founded this amazing organization where they raise awareness about SUDEP. They raise funds and actually do grants for people who are at high risk for SUDEP to help them buy and obtain seizure monitoring devices. And I just think they're an overall great organization to get to know. This is the Epilepsy Foundation, International League Against Epilepsy, and the Danny Did Foundation. And that is my talk. Here are my references. I'll go ahead and stop sharing. And I'm happy to take any questions, clarify anything, chat a little bit, anything that you guys want. Thank you so much for listening.